One quick housekeeping. The next 2 weeks we'll have short talks from our trainees, so please join us for those and help support the efforts of the laboratories and research efforts on the clinical side. There'll be 4 separate speakers each of those times, so please join to support them. But as far as today goes, it's my distinct pleasure to introduce UAB's very own Dr. Benjamin Greene. Dr. Greene is an associate professor in the Department of Otolaryngology, head and neck surgery. He initially received his medical training at SUNY in Buffalo, New York, after which he completed his residency at the University of Rochester. A little bit after that, we were fortunate enough to recruit Dr. Greene to UAB in 2014, where he first completed a fellowship in head and neck oncology and microvascular surgery before finally being hired as an assistant professor. In the subsequent years, he's taken on a number of responsibilities. In 2017, he became the director of the department's facial nerve clinic. And then the following year, he also became the director of their residency program. And then just a little over a year ago, he was promoted to associate professor, where he still sits now and continues to contribute to the teaching mission of UAB, treatment of our patients, as well as serving on several editorial boards outside of the university. He maintains research interests in quantitative technologies for postoperative fistula prediction, as well as surgical APGAR scoring for preoperative measures to predict outcomes. So very important stuff as far as patient healthcare is concerned. He's published well over 20 manuscripts, with work already published this year in the American Journal of Otolaryngology, and has an equal number of meeting presentations at both the national and international level. So with that as his introduction, Dr. Greene, thank you for accepting our invitation, and we look forward to hearing about contemporary management of facial nerve injuries and disorders. Thank you.
Hey, thank you very much. That was a good introduction. I feel pretty good about it. I mean, when the UAB experience for what we're going to talk about is a contemporary approach to facial nerve dysfunction, and basically what we do as we have facial nerve dysfunction, how we think through tumors in the parotid gland specifically, and if we do have to cut the nerve, or people do have nerve injuries, what do we do about it? So I have nothing to disclose, and well, there we go. But other than the fact that I'm a head and neck cancer surgeon by training, and the facial nerve stuff is kind of a adjunct to that because of the just the fact that we have to take these nerves for cancers all the time, and we didn't really have anything for. And so that's like, I'm the director of the program, but I also started the program, so I just made myself the director. It's nothing really all that fancy. But I put this here because I say my first love is head and neck cancer, and facial nerve stuff is just kind of what I do afterwards. But I'm not a facial plastic surgeon. I'm not a cosmetic surgeon. And part of the facial nerve program is seeing the folks, getting a plan, and referring them to people who do a better job than us, such as oculoplastics, plastic surgery, facial plastic surgery, and other cosmetic people that can do a better job. So I'm stealing from them when I put a lot of these pictures in here. And so I'm also from New York, and these are my kids who are wearing like gloves and a hat, sitting in front of a fireplace, and in 72-degree weather. So there's that. And I'm not going to go through a ton of facial nerve anatomy or pathology with you guys, just because it's crazy for me to go through pathology with your department. But the facial nerve is just anatomically, and I guess it's just a complex nerve. It's a bunch of neurons, how it travels throughout the skull base and the different canals it goes in are something, I still have to read every time I give a talk. And especially if I, have to take the boards, I would have to read that, the night before. But, it gives off somatosensory and secretomotor as well as motor function. And again, it's, there's different segments, meatal segment, the labyrinthine, which is the most narrow portion, and that's most likely where it's going to have a traumatic injury. Tympanic portion, which is from the geniculate to the second genu, and that is the most likely place it would have a surgical injury, because it can be dehisced in about 20% of people. inside of the middle ear. So if you're doing middle ear surgery, it could be just floating in the breeze and they're not covered by bone, and upwards of 1 in 5 folks. And then in the mastoid, it goes from the second turn and out through the skull base of the stylomastoid foramen. And as it moves through the skull base, it fasciculates until when it comes out to the level of stylomastoid foramen, you can, obviously see these fascicular bundles here, which has meaning as it splits up into different things in the extratemporal segment. So what I most am going to talk about today is the extratemporal segment. I don't do skull-based surgery anymore. I don't do neurotology for vestibular schwannomas and things like that. Or really mastoid surgery to find nerves and do that. In fact, I asked my partners to do it, and going on right now as we speak, one of my partners is doing a mastodectomy to identify a nerve where then we can graft it for a young woman who got shot in the face. And so she's doing that. I asked them to do that for me so that we can do the nerve graft. And that part's way harder than finding a little nerve and sewing it together. And so basically what we say is that, these nerves come out of the stylomastoid foramen. It branches at the pes anserinus, or goose's foot, into an upper division and a lower division. And we learn about, as we go through, to Zanzibar by motor car, tell Ziggy Bob Marley called to remember the branch of the facial nerve, but that doesn't really coincide with what we see in the OR. And these are just some pictures that we've taken as dissecting out the nerve to show you just the absolute variability of what the facial nerve and its branches can look like. And so this is, I'm a simple person, and to think through how nerve structures are like this. And so when you're thinking of identifying nerve injuries, you can essentially go by something called Sunderland's classification, which is really hard to tell what kind of in pictures like this, it's easy. But when you're thinking through, okay, did I really get a type 4 where it's like the epineurium's intact, but it's everything else is it not? You can't tell that just by looking at it, Pat, like looking at it in the patient. You could cut it out, look at the segment and see, I guess, but you don't really know that. So in theory, you could say this. And basically, if anybody has an endoneurial injury, perineural injury, or epineurial injury, you usually want to use surgery to recover this. And so neuropraxia, which is, just basically pulling on the nerve a little bit too much, has no Wallerian degeneration, we expect a full spontaneous recovery. And then if there's a slight injury going a longer route, then we expect Wallerian degeneration, but everything's intact. So it will spontaneously recover across that at the quoted rate is 1 millimeter per day, but it's really hard. It's really hard to figure out the exact numbers here. And so when you see these things and you're doing these intraoperatively, you're getting, this is somebody that had an acinic cell carcinoma. And this is the tumor that's going out between, it goes into this is a superficial segment, and you're seeing the upper division and the lower division, and this is right in between them. And then you see here is the branch dissected out, and this thing is injured right here, but we don't know, is it involved? Is it injured? We'd actually sent off the epineurium here, and it was not involved with acinic cell carcinoma on a frozen section. So we peeled it off and went forward with it. And I guess that's the same picture. So acinic cell carcinoma, isn't very neurotropic, I guess is the word, or it doesn't really go after nerves the same way something like an adenoid cystic carcinoma would, as you guys know. And this is a mastodectomy has been done here to kind of help with getting the nerve. These adenoid cystic carcinomas tend to be stuck onto the nerve. They can be a small tumor that knocks out somebody's face. This person had facial nerve paralysis preoperatively. And to get this out of the skull base, this person had a mastoidectomy done. This is the injured portion of the facial nerve. And then this is the facial, this is the stump of the facial nerve here cut with the arrow. And this is the other portion of it. And then this is sewn together under the microscope. And so just very simply, I'm going to go through clinical decision making, and I'm talking very simply because this is just a huge amount of thought that goes into this, both on your side and our side. Like, what does perineural invasion really mean? Are there skips? Like, what is it? What do we do about it? And I'm going to present literally 2 slides, I think, on it. And so a lot of the data on squamous cell carcinoma for facial nerve, and most of the best data comes from Australia, because you have a bunch of Western European people in a really sunny climate, get a lot of skin cancer and get a lot of parotid surgery. And so basically, this is looking at people who had clinical perineural involvement, both either on imaging or symptoms, versus incidental involvement that was found on pathology. And patients with squamous cell carcinoma and clinical perineural involvement had much worse disease-free survival and recurrence-free survival. That's when it's found on both the imaging or symptomatically. And most cases were treated with surgery and postoperative radiotherapy. And so when you're looking at the data, and just big picture is that if somebody has clinical perineural invasion with facial nerve paralysis, or findings on imaging that show nerve lighting up going into the mastoid with a known adenoid cystic or something, don't try to save the nerve. Like, just don't do it. Squamous cell carcinoma specifically, don't try to save the nerve. Cut it out and we'll graft it. But if the tumor is close to the nerve and it's not invading, but it's very kind of close to it, stuck to it, and they don't have any symptoms, the nerve's working fine. Basically, from the data review that I did this past weekend while putting together this talk, is that in a non-radiated patient, attempt to peel the tumor off the nerve, knowing that they're going to get radiation post-operatively. There's adequate treatment, and you could always go back in and do a radical parotid. You don't necessarily lose anything there. And a radiated patient have an extremely low threshold to resect the nerve. And I do. I almost, if somebody has a history of radiation and the tumor is near the nerve, they're in my hands, they're almost certainly going to get it resected, because having facial nerve paralysis is bad, but having squamous cell carcinoma of your face is invading your skull base is worse. And so when we started the facial nerve clinic, we really had the idea that it was going to be this big, surgical only facial nerve problem where everybody would come in because they had their nerve cut, or they had skull base surgery, or they had these tumors. And what we really saw is we opened up to everybody, and we really see that about 2/3 of the patients that come in, probably more at this point, are people that have idiopathic facial nerve paralysis, Bell's palsy, or caused by zoster, so Ramsay-Hunt syndrome. And so most of what we see are folks with that. And so that was an interesting thing, because we have to then figure out, okay, usually we don't treat those surgically. So we're going to utilize different techniques to help those folks. And so, everybody hears about Bell's palsy and being a 95+% recovery rate, but what they don't see is some of the synkinesis stuff that I'll show you here. And so this is a guy that I found that I did before we started the facial nerve clinic. He had a radical parotid, mastoidectomy, and I put I think an anterolateral thigh free flap there, or forearm flap. I can't remember which one. His face is drawn down. We didn't do any eye stuff yet. His eye won't close. And so that's him. And then while I was doing another one, this young lady had the same surgery done What you don't see is on here is she has a free flap with different color skin over here. And we, while I was harvesting the graft, I did a nerve graft. And I just grafted the nerve. It took an extra, probably 20 minutes. And now she has a result that's like, this is after 6 months and this is after a year. And I mean, I would say that's a pretty acceptable result for somebody that otherwise would look with their whole face dropping down, inability to close their eye. And this is even nothing that I would never do this now. I would do different things that we'll talk about. So, basically, facial nerve injury and dysfunction is pretty common, especially with Bell's palsy, zoster infections, but during facial surgery, neck dissection surgery. And long-term dysfunction can result in depression, anxiety, decreases in quality of life. And it's really requires a huge management team to figure this out. It's one small nerve, but it requires neurosurgeons and skull-based otolaryngologists to do the tumors and find the nerves at the skull base. It requires, people that have microvascular skills to put the nerves together. It requires cosmetic surgeons to do the lids and the facelifts and stuff like that. It requires, facial therapists to help with all the therapy that goes into, okay, you now have your masseter nerve going to your facial nerve. How do you use it? You clench your teeth so you can get a smile. How do you get rid of the synkinesia, relearn how to smile? And then, it requires people to get the Botox covered by insurance and all of these things as well. So a lot of coordination. And so when we started, it was June of 2017, which seems crazy that it was that's like 5 years ago to me. For whatever reason, I say 2017. I'm like, okay, that's 2 years ago. But it's the 5-year anniversary this June, which I didn't even realize until I was putting this together. We started off doing a half day a month. And like anything at UAB, once you build something, it just gets flown in, it just explodes. And so we're up to 2 clinic days a month, and we're probably going to do 3 full days pretty soon. So this is not true. This 133 is a typo. It's 333 from last I counted, which was 6 months ago. So we have over 300 patients that come from all over the Southeast. We've developed algorithms that we've published and management strategies. We basically involve everybody that wants to be involved. And it's like, this is not meant to take away stuff. It's meant to have a dedicated treatment plan. Like if you go to UAB, you get this treatment plan, and whoever's the best to do it. It's not an ego type thing. If plastics or oral surgery is better at doing this part, that's great. If obviously I'm not going to argue that oculoplastic surgeons are worse than me at doing eyelid surgery. They're way better at it. So if they have complex eyelid issues, they're going to them. And we have a facial therapist who's a speech pathologist that works with me on head and neck, our head and neck team. And so speech pathology is very well tailored to facial nerve therapy because speech and swallowing and chewing and everything is so affected. Whereas at other places, physical therapy is typically in charge of that. And so this is who it is. Allison Seaman is the PA that works with me. And Dwayne Trahan is the speech pathologist that is part of the facial nerve clinic. So everybody that comes into the facial nerve clinic is seen by the 3 of us right now. And we have another faculty member who's going to start seeing facial nerve patients as well soon, Harry J. Rajan, who helped me with the components of this talk. And so everybody gets facial grading, quality of life outcomes, and on validated patient-reported outcome measures. Everybody gets pictures and videos every time they come in. We have a prospectively maintained database, and we've added PHQ-9 depression screening and the GAD-7, which is generalized anxiety disorder 7-question database, because we've found out that we really have been missing patients who are depressed and we could intervene on. So again, the numbers are all over the place here, but we have over 300 total patients. 2/3 are Bell's palsy. Then we have parotid surgery, Ramsay-Hunt syndrome, skull base surgery, trauma, and congenital is much further down the list. When you think about facial nerve dysfunction, the first thing that was described, or the most commonly used scoring system, is called the House-Brackman score, and that was used for skull base tumors, where the nerve was either going to work or not because it hadn't branched out in the extratemporal segment. And so you know, 1 is normal, 6 is total flaccid, and 4 is the kind of the cutoff, because a person with 3 can close their eye, a person with 4 can't. And so that's how you typically think through it. And people use this all the time. It's really good for that. But when you're talking about more complex, like, okay, that parotid surgery and now their brow doesn't work, there's nothing on that can talk about how that can change. And so we use on the left side of the screen, the Sunnybrook facial grading system, which is how I grade everybody, that compares resting symmetry, symmetry of voluntary movement, how they move their face, and then when they move their face, do any other muscles move? So the degree of involuntary muscle contraction associated with every expression they have. So you see this after Bell's palsy, you know, quote unquote heals, the 95+% or whatever people that have healed, but a large number of those folks, you know, they can close their eye, their face moves, but they don't have their smile back completely. When they lift up, when they open their eye, their mouth moves. When they chew, their eye closes on that side, because as the nerve healing has happened, that it's kind of rewired itself so that they have synkinetic activity along the nerves. And then this is called the face scale, which is how the patients describe this, how they feel about it. So this is our objective score, and this is their subjective score about how they feel about it. And so this is, you know, we do everything from the fairly simple. This is a man who had this is his right side here, a right-sided parotidectomy, and he has right marginal mandibular nerve weakness. And when he puckers, he can't whistle, he has some drooling. And so this is something where we just did Botox to the left side of his depressor anguli oris, because you see as he moves, this is pulling down. And then basically when he smiles, it's even. And it's not perfect because we didn't get movement in the good side. We just paralyzed in the side that wasn't working, we didn't help it move. We just paralyzed the other side. But honestly, he's got like an absolute great result that probably no one who hasn't met him will know about it. And this is literally just Botox, like 5 or 10 units into this area right here. So in our clinic, the ENT sees them. Plastics is around if needed. We have seen with speech pathology, facial therapy, and a physician assistant or nurse practitioner. Ours is a physician assistant. We take histories, timing, duration, and you'd be shocked at how many, or maybe you wouldn't be, but I was surprised at how many cancers we actually found in this. People who were found to have, they thought they had Bell's palsy, but when you're thinking through it, you're like, oh yeah, it started and gradually, slowly started getting more and more paralytic or paralyzed. And I mean, we probably find one or two a month of skin cancers or some other type of tumor there. And we have the ability to do conduction studies quickly and imaging studies just like everybody else. There's no real ability to get imaging any faster. And so here's my kids again. Everybody has to show their kids on Zoom talks. That's a rule, I think. So our goals are to restore resting symmetry and tone, allow for voluntary movement, ideally with spontaneous mimetic expression. That means smiling when you aren't even thinking about it. Because, and I'll get to why, you know, having a masseter nerve where you have to clench your jaw to smile, you won't, unless you're extremely well trained on how to use it, won't really get that by just if somebody tells a joke and you laugh or something like that. Minimize the synkinesis, minimize the aberrant nerve function. And that's through facial therapy and surgery. And so when you're thinking about this is a little algorithm that we drew up. So is it idiopathic or viral? Is it from surgery? Is it from traumatic? Do they have facial nerve, total flaccidity? Do we think it's going to be permanent or temporary? If it's temporary, are they fully recovered, or do they have aberrant function as they recover? And the first thing you think about, obviously, is the temporary flaccid paralysis. What do you do? The biggest thing that you want to take care of, obviously, is somebody's eye, and using all kinds of tears, shields, physiotherapy. Sometimes we do, if I usually wait about 60 days. And if there's no recovery, I'll put a gold weight in their upper eyelid. When you're thinking of synkinesis and aberrant function, again, this is a Botox and physiotherapy. So if people come and they've healed, but you can see this is,
your eyebrows for me.
You can see at rest, he is twitching, and
Close your eyes gently.
and
Yeah,
you would say that he has a full recovery from a Bell's palsy.
Smile gently. Smile as big as you can. Okay. And then pucker your lips.
Eye closes.
Your bottom teeth out. All the way out. Yeah. Okay. And then look up at the ceiling for me.
Look at that twitching. It's just,
I'm going to have you.
that's miserable. And so we can get a little, that guy has it real bad. And so our results here are okay, but they're,
And then raise your eyebrows.
and so he gets a little less twitching, because the more Botox you put in here, the less likely he is to close his eye. But this is Botox fully working for him. But he has a more symmetric face, slightly less twitching. When he smiles, his eye doesn't totally close on that side. But the twitching still drives him crazy. And I've done enough Botox where I've made it so he can't close his eye or doesn't twitch at all, but it's and he hates that even worse. So it's tough to do. And so this is another person with Botox and physiotherapy.
And raise your eyebrows up for me. Close your eyes gently.
And I'm doing these to talk about, basically how, people that have a full recovery from Bell's palsy, what they look like. That's her best smile that she can do there.
Stick your bottom teeth out and raise your eyebrows up.
And so this is,
close your eyes gently. Close your eyes super tight as you can.
And she has less synkinetic movement with some Botox here. We're trying to get less of a deeply furrowed expression here. With facial therapy, a more even smile and more even puckering, more even teeth showing. And that's mostly, I tell people, mostly therapy, some Botox. And usually what we do is we have people do 2 months of facial therapy while we're getting the Botox approved. That way people really understand the therapy before getting before we do the Botox. Because once what we found early on is once we started giving people Botox, they would not use the therapy as much, because the idea was that the Botox was what does it, because you can see the quick result. But it's really the long-term goals are the therapy. And I tell them that 80% is therapy, 20% is Botox, but nobody listens to me. They just basically have the, it's a lot easier to just get the Botox and say, it doesn't work that well. And so dividing the face into thirds, when we're thinking through this stuff, if you're looking at, I've tried to choose, the perfect face. And so I found this one, and we do it basically from the eye and up is 1/3. The corner of the mouth and up is the 2/3 between the eye and the corner of the mouth for a smile. And then the lower lip is the third third. And so if you're thinking that flaccid paralysis is going to be permanent, did they have a short segment nerve loss? Like if you just cut it out in surgery, or they got a bullet in their face, like the lady that we're going to start operating on in a little while. So you can either lift it up and put it under no tension, or do a cable nerve graft. If there's no accessible proximal segment, such as you took it out at the skull base or at the brain stem, or major parotid malignancy that's going all the way up, you can do dynamic reanimation, which is what you would consider a 12/7 nerve reanastomosis, a cross facial nerve graft from the other side, or a static suspension, or masseter to 7 nerve graft, which is what I usually do. And then if they have no distal motor units, such as it happened over a year and a half ago, you have to do either a static suspension, which is just a glorified facelift where you're lifting people up, or an innervated muscle transfer, which is taking muscle, its blood supply and its nerve supply from somewhere, usually the gracilis muscle, and putting it up here and using some type of a nerve graft, whether it's a crossface nerve graft or a fifth nerve, to innervate it and using a free flap. So we'll first talk about primary anastomosis and cable graft. We use Axoguard nerve grafts. I don't get paid by them or anything. That's just the best ones that they make. Cable grafts, you could either use the great auricular nerve, which is, as head and neck surgeons, that's what we tend to use because we're right there. You can use the sural nerve as well, which is good. Or you can use a synthetic graft, which is a cadaver graft. We're doing research on this to see if they work as well right now, just retrospective stuff. And we wrap it with Axoguard, which is a matrix that doesn't have the nerve sprout from it, where it goes. And then dynamic reanimation with no accessible proximal segment. So this would be where we're talking about a 12/7 or a 5 hypoglossal or a masseter to facial nerve, or a static suspension. And so we do this when I say splitting the face up into thirds. We do this a static suspension on the upper third. This is a direct brow lift, which is the best type of brow lift on a facial nerve patient because it provides the most lift. A gold weight in the upper lid, which is literally just a piece of gold, and a lateral tarsal strip, which is eyelid tightening procedure. And so this is a direct brow lift, which is just making an incision here. The fancier brow lifts, which is where you do endobrows or pretracheal, where you cut along the hairline, doesn't work as well in facial nerve patients because of how much laxity there is. They have no tone to support the brow. And so this is somebody who was burning trash, and it exploded on him and cut his facial nerve to just the upper division. And so this is pre-op.
And birthday.
Charles Dickerson.
And so he still had some weakness of the lower divisions as well, but we were at first just you see how he has no movement here. He can't close his eye.
Super tight as you can.
He's got a little bit of closure, a little bit of movement here, but he has ectropion at rest here. And then this is direct brow lift. You can see the incision here, lateral tarsal strip to lift this up. I didn't put a gold weight because I thought his eyelid was a little bit heavy and didn't need it.
Raise your eyebrow, state your name and birthday. Close your eyes gently.
So he still can't move his brow, but his brow is at a better
Go
position.
ahead and open. Give me a gentle smile. Now
A little bit of
smile as
lower
big as
facial
you can.
weakness.
Pucker your lips. Say E to show your bottom teeth.
E,
Say 1, 2, 3.
1, 2, 3.
Happy birthday.
But you can see that at rest, his brow is at a good position.
Raise your eyebrow.
Other things for the middle and lower third that we can do. This is for somebody who you just want to get off the table quickly, older people, where you can do a static suspension for the nasal ala. As the face collapses, there's very little breathing. The breathing is impaired because of the nasal valve collapse. You could just basically wrap a suture around it using a needle, and that is a really nice quick way to get them breathing better, and patients actually love it. It doesn't last for that long. Orthodromic suspension, which is cutting through the nasolabial groove, going to the coronoid process of the mandible, and drilling a hole, cutting off the coronoid, drilling a hole in it, and suspending that so that the temporalis muscle can have a dynamic movement. I still call it static because it doesn't have that much movement. And static mid-face sling, which is what I usually use, tensor fascia lata. And so this is somebody who had brow, gold weight, lower lid tarsal strip, and a nasal valve. And you want this, like, see his nose like jacked up there. That's how you want it so they can breathe, because it's going to go down. And for these people that don't want anything done for it, like, this is the minimum that you want to do, because you want to close their eye and get them breathing.
Close your eyes gently. Close your eyes super tight.
So I won't show you the whole thing, but,
Raise your eyebrows.
and you want to, everything with facial paralysis, you want to overdo a little bit so that you can, because you know that over time, gravity is going to win this battle. And this is where I put the needle and passed that suture.
Raise your eyebrow. Raise your eye.
Orthodromic sling, like we talked about, I've done a fair number of these, but my practice has really switched to doing the tensor fascia sling. I think the results are better overall. These are two people early post-op after an orthodromic sling. This is a few months afterwards. This man had a chondrosarcoma of his stylomastoid frame, and so he took this out, did this. He actually also couldn't hear, so he got a cochlear implant at the same time. And so I was getting very little movement on these, and then I was using monopolar cautery, but because he had the cochlear implant, I used bipolar, and I found out that I got a lot more movement on him. But I'm yelling at him because his cochlear implant's not on, and it's like, I should know that that doesn't help. Like if anybody, it's like, no matter how I yell at him, he still can't hear me because the implant's not turned on, but you'll hear me yelling at him in this video.
And then just relax.
And so you can see that he gets a little bit of movement here that's from the temporalis. I'm trying to smile. And then this is a woman who was 1 week post-op here.
So try to
and we pull that out. And so she's just kind of showing the movement that she can get from here. And this will, obviously heal a little bit better, but
smile. So try.
Where's next? So dynamic reanimation is in people that have had nerve injuries less than 1.5 years, and then but also have no ability to graft the nerve. And so before we started, there were people here that would do 12/7 on nerve transfers. People get terrible synkinesis, but they do get resting tone, which is good because the hypoglossal nerves has a firing rate at rest, and so the masseter doesn't. So you can have tone at rest with this, but not with this. But the synkinesis is terrible with this, and you have tongue dysfunction because you usually do an end-to-end on the hypoglossal, where you have to cut the nerve completely and then cut it and sew it to the facial nerve. This is not doing that, but people very rarely have luck going end to side on a nerve like this. And so this is a masseteric nerve transfer. And what I post this for is because this is a theater actress, and this is what she came in for. And then I say, smile, and she can get this. And that's like, we look and we say, okay, look at how great that is. Like, she looks so much better now because she's getting this. But when you have her talk, it's a kind of a different story. And I've changed.
And raise your eyebrows up for me. Relax.
And she is someone who has
Close your eyes
very
gently.
lax skin, which is a terrible patient
Yeah,
for
squeeze
facial
your eyes
nerve
shut.
surgery. But we have no other options.
And relax. All right. And then smile gently. Smile as big as you can. Good. And pucker your lips.
Get the picture there. And then this is
Raise your eyebrows. Close your eyes.
at rest.
gently.
She's still sagging here, but she gets good eye closure.
As tight as you can. Go ahead and open your eyes. And gentle smile. Smile as big as you can.
And so I'd call that a decent result. But when she puckers, nothing.
To show your bottom teeth.
When she says E, she has nothing. You'll see when she talks. When she talks, it looks like she has facial paralysis. So this is somebody that we could get decent for pictures, but we didn't. Right now, at the time, I would do a facial sling at the same time, which I didn't do for her. This is the first 5/7 done at UAB. And she is a theater actress, and so she won the award for I think the Northwest Alabama Best Actress Award. And then a month later, she got her acoustic neuroma removed, and so that's here. And then she had to give the award the next year to the person, and then that's here. And so she's overall happy because she's getting pictures taken with it. We've since had one of my colleagues do a facelift on her, and it's like a work in progress. This is somebody who had a self-inflicted gunshot wound to the ear, and never showed up
Raise your eyebrows up.
afterwards. So this is, he has good tone. So at rest, he
And
doesn't
close
look
your
that
eyes
bad
gently.
because he's young. He's like 28,
Now squeeze them shut.
but he has no movement here, and his nerve is gone, shattered in his ear. So nothing to graft to. And then this
Raise
is
your eyebrows.
brow lift. So it doesn't move still, but we can get it at the same level. Get his eye closed.
Close your eyes super tight as you can. Okay, go ahead and open your eyes.
We've also since gotten a tripod for our clinic, so it's less shaky camera work.
Now smile as big as you can.
And so it gets some movement here, which is what we want to see. And just having a little bit more tone and getting it done more quickly can help
Close your eyes.
that. And then this is a couple months later.
Smile.
Where he just showed up to clinic. And so that's what we want to see, is something like that.
Smile like. Show me your teeth. When you smile.
He also has an open bite deformity, which makes it easier for him because it's a clench. He can kind of smile without doing it. And this is with no training. So if he had come in for training, he would have gotten probably a better result. So crossface nerve grafting, this will get you spontaneous facial expression because in theory, you're hooking up to the side that works and coming over to the side that doesn't. And then getting along, getting better expression, better normal spontaneous expression. You need a sural nerve harvest. It's a long distance, and crossing that gap, you get a less of a neural load than you would for even a 5-7. So we don't do it that much unless it's in the context of putting a gracilis free flap there. And that is where we're coming into somebody that has no motor units. It's been over a year and a half, 2 years since they've gotten facial paralysis, but they want something done. So free muscle transfer, this is a gracilis muscle with the obturator nerve. We've done 3 here and we don't have the results totally back yet because it takes about 6 months to a year to see them. This is somebody here that we did sewing it in and basically using a free tissue transfer where we sew the blood vessels in the neck and harvest here. And so what you can see is this is in the leg, it's totally detached. There's the obturator nerve, we're stimulating it. You can see this, and what we're doing is trying to use this muscle to pull just for a smile. It's not, it's not a perfect situation, but we're literally just trying to get a smile for this person.
Okay.
And so this is part of the facial nerve team. This is Allison, who is a PA that works with me. This is Renee Myers from Plastics. He's the co-director of the Facial Nerve Clinic. Harry Jayarajan, who is a faculty member that's going to start seeing facial nerve patients as well as and me. And this is basically the major facial nerve players. It's got to be updated because a couple people have left, but as of when we first started, this is the first flyer that we had. And so that is all I have for you guys today. I would appreciate any questions that you have. And thank you so much for having me. I appreciate it.
Great. Thank you so much for that. Definitely learned a lot. It always amazes me with surgery how much team effort it is as far as all the therapy and everything else that you have to coordinate to get it successfully done. I guess one question I had as other people decide if they're going to unmute is with some of the examples with Botox, how frequent do they have to come back in? Is that then for the rest of their life? Is that one and done? I mean, how permanent are those types of therapies?
So Botox is not permanent, and
Yeah.
Botox is like a haircut. I tell people it's like if you really hate it, your face comes back in 2 to 3 months. If you really love it, same thing. So it's about 3 months is the time period that Botox lasts for. It's a rest of life thing. As they do more therapy, the amount of Botox that they need lessens. And the nice thing about facial nerve paralysis, well, there's not that much nice about it, but is that it's not like my head and neck cancer clinic. I tell patients this, we can take this as far as you want to, and if you want to come in and get Botox every 3 months, I've had people that have come in every 3 months for 5 years. And I've had people that have gotten it a couple of times. They're like, you know what? It's not really worth me driving from Mobile to UAB every 3 months, which is fine. It's for the people that we're treating with Botox, they're usually for synkinesis. If they've learned to live with it, that's great.
Okay, thank you. And then the other question that kind of came to mind, and I guess this wouldn't be applicable in the acute trauma type nerve paralysis, but in some of the familial versions, is there any use of our department for you guys as far as, do you take any biopsies and send them off for pathology and dictate treatment by any underlying molecular readout or anything like that?
You know, the way that you guys help out is really with the knowing if the margin is in the nerve or not, you know, and if it's in the epineurium or not. And I think that's probably, you know, anybody who's spent time in the frozen room probably knows how much ENT loves to send frozen sections for everything. But that would be one where it would really make a huge difference on the course of how we're going to do this, based on, is it involving the epineurium or not? And if it is, then I think you make a pretty strong case to take out that facial nerve.
Great. Thank you. Are there any other questions from the audience? Okay. Well, thank you again, Dr. Greene. It's really good to see the patient care that goes on here at UAB and see all the impact that you have on these people's lives. It's very impressive. So thank you so much for sharing that with us.
Thank you so much for having me. I appreciate it.
Okay. I hope to see you all next week. Have a good day.
Take care. Yep.
Bye.